I am going to focus on three important peripheral nerve blocks and two important facial plane blocks for the lower extremity. I have no conflict of interest. The illustrations or schematics used in this presentation are my drawing, and I have taken the appropriate patient's consent. I will be discussing about the landmark and the PNS guided technique during my lecture, and will demonstrate the ultrasound scanning technique on volunteer. Let's begin with a simple block that has high success rate and low risk of complications. Femoral nerve block is performed to provide analgesia for various hip and knee surgeries. We at Ganga Hospital also use it as on-arrival block and analgesia for positioning before neuraxial block in hip fracture patients. Femoral nerve is the largest branch of lumbar plexus formed by the posterior division of ventral primary rami of L2, L3 and L4 spinal nerves. It emerges from the posterolateral surface of the psoas major muscle and enters the thigh by passing deep to the inguinal ligament. In the thigh, it divides into anterior and the posterior division 2 to 3 cm distal to the inguinal ligament and proximal to the inguinal crease. The anterior division has one muscular supply, that is nerve to sartorius, and rest are sensory branches. Whereas the posterior division has one sensory supply, that is saphenous nerve. It supplies the medial side of the leg up to the ball of the great toe, and rest are the muscular branches. If you look at the anatomy and the sonoanatomy, the vein, artery, nerve, these three structures form a Venn relation from medial to lateral, and the femoral nerve lies outside the femoral sheath and deep to the fascia lata and fascia iliaca. In fact, it is encased by two layers of fascia iliaca, and here you can see the hyperechoic elliptical femoral nerve lateral to the femoral artery and on anteromedial surface of the iliopsoas muscle. In PNS guided femoral nerve block technique, first identify the anterior superior iliac spine and the pubic tubercle, draw a line joining these two, and next palpate the lateral most border of the femoral artery. The point of needle entry will be 1 cm distal to the inguinal ligament and 1 to 1.5 cm lateral to the femoral artery. A nerve block needle is inserted at this point in a cephalad direction at 45 to 60 degree, and sometimes you might get sartorius contraction as shown in the video above. You can get sartorius contraction, that is because of the stimulation of the anterior division. In that case, just redirect your needle laterally and posteriorly to get the patellar dance or snap, that is due to stimulation of the posterior division of the femoral nerve. Once you get the desired evoked motor response at 0.2 to 0.4 milliamps, deposit 15 to 20 mils of local anesthetic after negative aspiration for blood. The sensory assessment, we do it by checking the cold sensation on the medial aspect of the leg, and the motor block can be assessed by checking the strength of the quadriceps muscle and by asking the patient to kick or punt against the resistance.